afternoon, everybody. On behalf of Apollo Hospitals and Apollo Hospital BP Clinics, I invite you all to this World Hypertension Day celebration. We are going to have a session on hypertension with some of the stellar consultants at Apollo Hospitals, providing you insight on hypertension. The theme of World Hypertension Day this year is measure your blood pressure accurately, control it, and live longer. I will give you a brief introduction of hypertension, about hypertension in India. We already know from the population-based studies that a few millimeters of lowering of systolic blood pressure can make a big difference in a patient's life. In this graph, you can see that 2 millimeter reduction in systolic blood pressure reduced stroke by 6 millimeters and coronary heart disease by 4 millimeters of mercury. 5 millimeter reduction in systolic blood pressure reduced stroke by 14% and mortality related to coronary heart disease by 9%. Now, how are we doing with our blood pressure? What's our report card? If you look at this recent survey of Indian population about hypertension, you can see the awareness of hypertension in those who have hypertension was only 42%. Only 42% of people who had high blood pressure knew that they had high blood pressure. And of these 42%, only 38% were on treatment. And of these 38% who were getting treatment, only 20% were under control, which is quite dismal. And this is worse. These numbers are much worse in the rural India. If you look at a developed country like USA, the numbers are much better. But if you go back and look 20 years or 25 years back in USA, when the first JNC guidelines came out, they had also similar dismal numbers, which they have worked hard and achieved better numbers now. So it's incumbent on us to work on it and improve blood pressure control, blood pressure awareness in our population. In addition, we have some special unique features in the patients who have hypertension in India. We have much younger patients who get hypertension. We have a big rural divide. Patients in rural areas do not know they have hypertension. Their blood pressure is worse controlled when compared to the urban areas. And then these patients who have hypertension have a lot of comorbid conditions like diabetes, cardiovascular disease, stroke, etc., and renal disease. And the early hypertension-mediated organ damage is also much higher in Indian population than when compared to other developing countries. So before I go forward, I will introduce the speakers today. We have, I'm Dr. Muhammad Abdul Rafi. I'm a nephrologist and hypertension specialist. I will be talking about 24-hour blood pressure monitoring. After me will be Dr. BVA Rangareddy. He's MD, DM in cardiology, one of the consultant intervention nephrologists at Apollo Hospital, Jubilee Hills, Hyderabad. And he will speak on the non-pharmacological and pharmacological approaches to control hypertension. After him, we have Dr. Varsha Kiran. He is also a consultant interventional cardiologist, and he will speak on managing resistant hypertension in clinical practice. Following him will be Dr. Gokul Reddy, another interventional cardiologist and a senior consultant at Apollo Health City, Hyderabad, with over 20 years of experience. We may belong to different specialities like nephrology and cardiology, but one thread joins us all is our passion for managing hypertension. So coming to my topic of 24-hour ambulatory blood pressure monitoring. The reason I chose this topic was partly because the theme of this year's blood pressure World Hypertension Day is measure your blood pressure accurately. And the gold standard to accurately measure blood pressure is hypertension is by doing a 24-hour blood pressure monitoring. Now, why do we need to monitor blood pressure beyond physician's office? You see this mercury manometer, it has been phased out, but even the ones that we have now, this technology has been in use for almost 120 years now. It was introduced in early 1900s and we were still using it. And on a population basis, it provides us enormous value, but when it comes to individual patient, it gives a very poor estimate of what's happening with our patient. There are patterns of blood pressures that we cannot identify through office blood pressure. There is inherent variability in the blood pressure that makes the office blood pressure monitoring inaccurate. And now when we do this casual office blood pressure monitoring, if we do not follow the guidelines, we may not get the accurate blood pressure. You can see here if the patient did not sit for 5 minutes quietly, the blood pressure goes up. If he does not have a chair with a backrest, the blood pressure goes up. The patient does not put the feet flat on the ground, the blood pressure goes up. And if the doctor relies only on the first blood pressure measurement, then the blood pressure will not be accurate. Because of the alerting response, most patients, 60% of the patients have what we call as white coat effect, not white coat hypertension. This is white coat effect, because of which the blood pressure may go up for a few minutes and then come down. So what do we do when the office blood pressures are not accurate? There are two modalities that are being increasingly recommended by the international societies of hypertension. And one is home blood pressure monitoring, and the other is 24-hour ambulatory blood pressure monitoring. Now, in today's topic, we will cover 24-hour ambulatory blood pressure monitoring. It's a simple device, cell phone-like device, which we put it with when the patient comes into our office. We place it on his belt, and there's a cuff attached to it. And this device is programmed to measure blood pressure every 15 to 20 minutes so that even when the patient is sleeping, the blood pressure is being recorded. He comes back the next day after 24 hours, and we download all these readings, about 60 to 80 readings, and the average of these readings are supposed to be the most accurate way of measuring blood pressure. What do we get? We get a graph like you see, the one you see here. We get the clinic blood pressure when the ambulatory monitor was placed on him. We get the home blood pressure monitorings and the systolic and the diastolic. We also get a insight about the nocturnal dip. Normally we have and I'll go into more detail later, 10 to 20% of nocturnal dip. And if there is any early morning surge, you know that early morning surge is associated with strokes and heart attacks in the morning. So we get an insight of that too. It gives us an average summary of 24-hour blood pressure. You can see that in the on the top. The average here for this patient was 119/68. And then we get wake time blood pressure, which is the daytime blood pressures, and we get the nighttime blood pressures. You can see here the average nighttime blood pressure in this patient was 104/58, which is lower than the daytime blood pressure, which is normal. So why do we call it gold standard? The reason is it's been extensively studied, and the normal values have been derived from large population-based studies. For any new measurement to be standard of treatment, we need to do, in this Pamela study, what they did was they did blood pressures for normal population, and then they corresponded that blood pressure with the office blood pressure of 140 and 90 to see what blood pressure falls in that range. And they found that those who underwent 24-hour monitoring, 120 to 130 systolic and 75 to 81 diastolic blood pressure was in the corresponded to 140 over 90. There's another way of doing it, and which was done in 24-hour ambulatory monitor. They did they pooled the data from several 24-hour blood pressure monitoring studies where even normotensive people were included, and they found, and they looked at the cutoff point for the 95th percentile, and what they found was 133 over 82 was above the 95th percentile range, and which they said that this is higher, this is hypertension. And the best way is to follow these patients in general population with 24-hour blood pressure monitoring for a period of time. In this Ohasama study, they were followed for 6.2 years, and they found that the cardiovascular and non-cardiovascular mortality went up after when the blood pressure 24-hour average blood pressure range went above 120 to 123 systolic and 65 to 78 diastolic. Based on these studies, international guidelines for the past 10 years have come up with these numbers. The daytime average number, which is equal to or more than 135 over 85, nighttime average 120 over 70 and above, and the 24-hour average of 130 over 80 and above. Generally, most guidelines prefer that you base your criteria for hypertension on the 24-hour averages rather than daytime or nighttime blood pressures. Now, if you look at the 2019 guidelines that came out from the Indian Hypertension Society, we follow the same as the other international societies, which is average of 24-hour blood pressure of more than 130, equal to or more than 130 over 80. So what are the patterns of blood pressure that we find when we compare a patient who has undergone office blood pressure measurement as well as 24-hour blood pressure measurement? So if the blood pressure is normal in the office, and then we are still expecting that he might have higher blood pressure outside the office, or he complains that the blood pressure has been high, then we do a 24-hour blood pressure monitoring. So if office blood pressure is normal and 24-hour blood pressure monitoring is normal, then it's true normotension. But then if the blood pressure was high and you are expecting it may be white coat hypertension, and the patient says, no, I checked it outside, it was okay. And it turns out when you do a 24-hour monitoring, both are high, office blood pressure as well as 24-hour blood pressure are high, then that is sustained hypertension, what used to be called as essential hypertension. And if the patient's blood pressure was high in the office, but when you did the 24-hour monitoring, it was normal, then it is white coat hypertension. And we'll go into detail of these. So in most studies in Europe and Japan, the range has been the prevalence has been between 10 to 20% based on the population the study was done. In the Indian ambulatory blood pressure monitoring survey that was done a couple of years ago, in 27,000 patients in 540 centers, they found that 20% of the patients that were referred for management of hypertension had white coat hypertension. On the other hand, there is another entity that we find on 24-hour monitoring, and that's masked hypertension. Interestingly, these patients are always normal, and I'll show you some examples later whenever they come to your office. But when they are walking around outside in their homes and in their office and when they are sleeping, their blood pressure are much higher. So these patients are being undertreated. Once again, 10 to 20% in European and Japanese studies, but in Indian ambulatory blood pressure study, it was found that 13% of the Indian patients who were referred for management of hypertension had masked hypertension. So what is the role? Somebody already has a hypertension. Why do you need to do a 24-hour monitoring? So this was a study done. This was one of the first study actually by Dorothy Perloff and was published in JAMA in 1983. What she did was these patients who were treated on-office blood pressure, she looked at their 24-hour monitoring, and she found that those who have higher blood pressure had worse cardiovascular outcomes. So that was the first hint that 24-hour blood pressure monitoring is here to stay. Now, a more recent study published in New England Journal of Medicine by Clement, what they did in this study was that these patients were being treated based on office blood pressures. Now, they divided these patients roughly like mild, moderate, and severe hypertension. They are already on treatment. So they divided into three groups: mild, moderate, and severe hypertension. And then they subclassified these patients based on 24-hour blood pressure monitoring into controlled and uncontrolled. What they found that you can see here in each category, in the mild, moderate, and uncontrolled hypertension, in each category, those who were found to have not good blood pressure control on 24 hours did not do well in terms of cardiovascular outcomes at 5-year follow-up. So even those patients who are being treated, if we can do and look at their 24-hour monitor, we may be able to help them. Similarly, this study by Vordacchia in Italy, they followed these patients who were being treated on office blood pressure. They followed them up at 3.7 years, and then they looked at those who were controlled on 24-hour blood pressure and those who were not controlled on 24-hour blood pressure. They are all being treated based on office blood pressure. So those who were controlled on 24-hour blood pressure monitoring, also they had 36% reduction in cardiovascular events. Now, we get these different readings, 24-hour readings, nighttime readings, daytime readings, office readings. Which one is the best? So this study done by John Stayson a few years ago showed that the best, you'll be surprised, the best measurement is the nighttime average. Because one of the reasons is these are very stable blood pressures. You have no sympathetic drive, no excessive sympathetic drive. These patients are lying down. These patients are probably sleeping. And so this turned out to be the best, followed by 24-hour average, which is in the blue, and followed by the daytime blood pressure, which is in pink. And you can see the red one, the office blood pressure, the conventional, it just falls by the wayside when predicting the cardiovascular events. So in conclusion, even in those who have a sustained hypertension and who are being treated, I think it is necessary once in a while to get a 24-hour blood pressure done to see whether we are doing our job well or not. This is white coat hypertension. This is a patient that I followed a few years ago, and his blood pressure always in a number of visits was found to be excessively high. You can see 170, 84, 164, 84 and all that. But he would say that his blood pressure is all right outside. So we did a 24-hour monitoring, and you can see the dark lines on the top actually are above that, that's the cutoff above which patient has either hypertension or already has hypertension. We call it uncontrolled hypertension. So this patient's blood pressure was very well, in fact low actually. He was being over-treated because of the white coat hypertension. His systolic blood pressure on 24-hour average was 99 millimeters of mercury, and diastolic was 55 millimeters of mercury. So this is an example. Why does this happen? In whom does it happen? More in elderly, more who are smokers, more who have cardiovascular disease, and more who are already on treatment. The pathophysiology is unclear, and what do you do? Most of the time we don't do anything except we individualize the treatment. You look at the cardiac, you look at the echo, is there an LVH? You look at the proteinuria in the urine, does he have microalbuminuria? You get the eyes tested for retinopathy. So in case you're feeling that he already has hypertension mediated end organ damage, then you may opt for some treatment. Masked hypertension. So these are the patients who have who come to your office repeatedly with normal blood pressures in the office, but they walk around with very high blood pressure. And this is an example of that This patient comes to my office repeatedly. His blood pressure is 126 over 86, the third blood pressure, always normal. But he says his home blood pressure is like 125 over 100. So we do a 24. This is again another visit of his, but we do a 24-hour monitoring, and you see that the graph shows that his blood systolic, diastolic, nighttime, all the blood pressures are very high, and his average blood pressure, 24-hour blood pressure, was 147 over 102. The daytime was also very high. The nighttime also was very high. So what happens in these patients are, because we underestimate their blood pressure, hypertension levels, we don't treat them appropriately. As a result, they are at higher risk for cardiovascular and renal damage. Who are the patients who have masked hypertension? Those who are smokers, those who take more alcohol, less physical activity, those who are stressed outside. That physician's office is the only place where they feel, relieved. So, or those who have CKD, so chronic kidney disease. And you can look at the target organ damage comparison in various patterns of blood pressure, and you can see the true normotension and white coat hypotension. The left ventricular mass index is almost same, normal, but when it comes to sustained hypertension and masked hypertension, it is high. So masked hypertension, you are thinking this blood pressure is okay in the office, he's doing well, but he is not. If you look at the cardiovascular event, in fact, in this, the masked hypertension has worse hazard ratio for cardiovascular events even compared to sustained hypertension, because he is not being treated at goal. So in conclusion, for masked hypertension, we need to be careful, we need to keep it in mind, and if we get a chance, we should get an ambulatory monitoring. We can also do a home blood pressure monitoring and get a masked hypertension, but we are still going to miss out the nighttime nocturnal hypertension. Now there's another entity that the 24-hour blood pressure monitor identifies, and that's dipping status. Normally at night when we are sleeping, our blood pressure goes down by 10 to 20%. It should go down. If it does not, then we are in trouble. So there was this large study, Ohasama study, that showed that non-dipping per se itself is a independent indicator of cardiovascular outcomes. In this study, when compared to those who were dipping and had normal blood pressure, it predicted the risk of cardiovascular mortality was 5 times higher. Now, what's the problem with dipping? Dipping never came into the prime time, and the reason is reproducibility. At best it is 60% reproducible, which means that if you repeat a 24-hour monitor, he may not dip that time. So that's why it's still not on prime time. Now, another entity that is increasingly being recognized is the nocturnal hypertension, which is a subtype of masked hypertension. And in the Indian ambulatory blood pressure study done a few years ago, 12% of patients who were referred for hypertension were found to have masked hypertensions, nocturnal hypertension. So this is an example of nocturnal hypertension. You can see the daytime blood pressures are very well controlled. This is the daytime and this is the daytime, and the nighttime blood pressure is higher. It should have been below this line, but it is much higher than that. So what are the guideline recommendations for 24-hour blood pressure monitoring? Most guidelines for the past 15-20 years have been recommending that wherever 24-hour ambulatory blood pressure monitoring is available, they should try and confirm the blood pressures if the patient has a hypertension or not with 24-hour monitoring. Now, the hesitancy in obligating physicians to do the 24-hour monitoring is because, one, the availability. Second thing, it's a slightly expensive modality of measurement. So that's why they have been hesitating. Indian guidelines, the 2019 guidelines say that ABPM is useful to identify white coat hypertension, masked hypertension, nocturnal hypertension, resistant hypertension, episodic hypertension, and those who are already on treatment. I showed you the data that those who are already on treatment based on office blood pressure, it is always better to once in a while check their 24-hour blood pressure monitor to protect them better. So in conclusion, 24-hour blood pressure monitor is an important modality, not only to measure blood pressure accurately, but also to identify patterns that we may otherwise miss, and to treat our patients to goal, and to prevent them from excessive damage, target organ damage, and to protect them from higher cardiovascular, renal morbidity and mortality. Thank you very much. And after me, Dr. B.V.A. Rangareddy will speak on the management of hypertension.
Hello, hello, hello. Okay. Okay. Good afternoon, everyone. Myself, Dr. Rangareddy, consultant cardiologist from Apollo Jubilee Hills. Today, my topic, I'm going to talk about non-pharmacological and pharmacological management of hypertension. So, as a brief introduction, hypertension is one of the leading causes of the global burden, and it doubles the risk of cardiovascular disease and coronary heart disease and heart failure and strokes and peripheral artery disease. So, it often associates with additional CVD risk factors, and also the risk of CVD increases with the total burden of the risk factors. So, although antihypertensive therapy clearly reduces the risk of cardiovascular and renal disease, large segment of the hypertensive population are either untreated or inadequately treated. So, as Sir already discussed about the prevalence of hypertension in India, the crude prevalence of hypertension is around 25.3%, and the unexpectedly high prevalence of hypertension among young adults in India, which is ineffectively treated, will likely result in longer lifetime exposure to these risk factors and thus higher CVD rates in the future. So if you see the burden of hypertension in India and urban and rural areas, as the years comparatively from 1977 to 2014, the exponential increase in the hypertensive burden is, you can see the graph. So the continuous increase in prevalence is noted in India, especially around 378.5 million Indian adults suffering from hypertension. So coming to the classification, as we know, the normal blood pressure below 120 and 80, and pre-hypertension comes 120 to 139, and diastolic of 80 to 89, and stage 1 hypertension 140 to 159, stage 2 more than 160, and diastolic of more than 100, and isolated systolic hypertension of more than 140 and diastolic less than 90. So around 80 to 95% of the hypertensive patients are diagnosed having essential hypertension, also referred as primary or idiopathic hypertension. In the remaining 5 to 20% of the hypertensive patients, there's specific underlying disorders causing elevation of blood pressures can be identified, that is called secondary hypertension. So primary hypertensive risk factors are age, alcohol, cigarette smoking, diabetes mellitus, elevated lipids, excessive sodium intake. Even the genetic family history, obesity and ethnicity, sedentary lifestyles, stress. So elevated BP without any identified cause, that's called primary or essential hypertension. It accounts for almost 95% of the all cases of hypertension. So cause may be unknown. Contributing factors like increased sympathetic activity or production of sodium retaining hormones and vasoconstrictors, increased sodium intake, and some modifiable risk factors, they're mainly hereditary, interaction of genetic, environmental and demographic factors which is associated with the primary hypertension, and water and sodium retention. Mostly 20% of the patients with high sodium diet develops hypertension, and altered renin-angiotensin mechanism found in 20% of patients, stress and increased sympathetic activity, and insulin resistance, hyperinsulinemia, epithelial cell dysfunction. So this is just a diagram which shows the effect of different, as we discussed, like sex and stress, genetic, mainly angiotensin, GRA, and sympathetic activity from CNS, and increased cardiac output, and sodium retention in the renal dysfunction, and gastrointestinal, mainly obesity, and insulin, aldosterone abnormalities, and age. All these factors affect on the smooth muscle cells, and increased resistance and peripheral vascular resistance. All these are the pathophysiological mechanisms which causes the hypertension. So these factors, as we discussed, these mainly increase the preload, increased contractility, functional constriction, and structural hypertrophy, which causes the increased cardiac output, and it causes the inability of the autoregulation and causes hypertension, and the increased peripheral resistance also causes the inability of autoregulation and causes the hypertension. So secondary hypertension, secondary hypertension is from mainly we see 5+% of adult population, mainly coarctation of congenital narrowing of aorta, renal disease, renal artery stenosis, and parenchymal disease, endocrine disorders like pheochromocytoma, Cushing syndrome, hyperaldosteronism, neurological disorders like brain tumors, head injury, sleep apnea, sympathetic stimulant medications, pregnancy-induced hypertension. So all these things are secondary causes, secondary hypertension. These specific causes like 5 to 10% of the adult population see. Cause of systolic hypertension with wide pulse pressure, it is mainly due to the decreased vascular compliance, arteriosclerosis, and increased output, aortic regurgitation, thyrotoxicosis, fever, fistulas, and patent ductus arteriosus. So hypertension, it may lead to coronary artery disease, stroke, heart failure, diabetes, renal disease, and this hypertension along with dyslipidemia causes this endothelial dysfunction, which in turn causes this coronary heart disease, and vascular strokes, and parenchymal disease, and peripheral artery disease. So hypertension and stroke, approximately 16 million people worldwide are affected by stroke per year. So high prevalence of 60 to 80% seen in elderly population, and blood pressure above 110/75 millimeters increase the incidence of both coronary artery disease and stroke. Each 20 millimeters rise in systolic blood pressure and 10 millimeters doubles the risk of stroke. So this progression from the hypertension, which leads to the heart failure, mainly left ventricular hypertrophy and myocardial infarction, which causes LV remodeling, diastolic dysfunction, systolic dysfunction cause the congestive heart failure. So this is the mechanism where the hypertensive kidney injury, when normal kidney, which has increased activation of RAS system and metabolic factors, which finally leads to increased sodium absorption and vascular resistance and sodium retention, which in turn causes increased blood pressure. So hypertension and diabetes are linked mainly insulin resistance in the nitric oxide and hyperinsulinemia, sodium fluid retention and hyperglycemia. It in turn stimulates the RAS system. So genetic factors, different genetic factors which causes the hypertension with these different mechanisms. So cardiometabolic risk factors, mainly as we discussed before, smoking, physical inactivity, unhealthy eating, inflammation, hypercoagulability, abnormal lipid metabolism, overweight, obesity, age, family history, genetics, all these causes the increased high risk. So mainly when a patient comes, we need to take the proper history, duration of the hypertension, previous therapies, responses and side effects, family history of hypertension and cardiovascular diseases, dietary and psychosocial history, and other factors like weight change, dyslipidemia, smoking, diabetes, and physical inactivity. The relevant history is very important, mainly to rule out the evidence of any secondary hypertension, evidence of any target organ damage like history of any TIA, stroke, angina, myocardial infarction, congestive heart failure, and sectional function. Symptoms, most of the patients will be asymptomatic, and specific symptoms to their blood pressure elevations, mainly hypertensive headaches or non-specific symptoms like dizziness, palpitations, easy fatigability, and impotence. And when such symptoms are present, they are generally related to hypertensive cardiovascular disease or to manifestations of the secondary hypertension. So measurement of blood pressure, as we discussed before, at least 2 measurements should be made, and ambulatory BP monitoring, which is very helpful for the diagnosis, and it's a gold standard. And laboratory testing coming to to diagnose if any secondary involvement of hypertension, mainly renal system and endocrine, metabolic, and fasting glucose, lipids, serum sodium and creatinine levels, hematocrit and electrocardiogram and echocardiogram needs to be done to rule out any secondary hypertension. So these are the investigations where mainly we do for to rule out secondary cause of hypertension. And non-pharmacological treatment and prevention, coming to non-pharmacological treatment is the mainstay, like initial grade 1 hypertension, and non-pharmacological treatment initiation is very important. Eat a healthy diet, fruits, vegetables, low fat diet, limit alcohol intake and cutting down on sodium intake, and physical activity, more than 30 minutes of physical activity on most of the days, and quit smoking. Lifestyle changes and blood pressure control is very important, plays a very important role in blood pressure control, even along with the pharmacological treatment. Mainly weight loss, DASH type of diet, reduced salt intake, physical activity, and moderation of alcohol intake. If you see the DASH type of diet, if you take on a continuous diet control, you can see around 8 to 14 millimeters mercury reduction of the BP. And physical activity can reduce 4 to 9 mm mercury. So weight loss also can add 20 millimeters mercury per 10 kgs weight loss. So these plays a very important role in control of the hypertension. And if you come to the pharmacological treatment, that different groups of drugs, mainly diuretics and beta blockers and calcium channel blockers, AC inhibitors, and angiotensin receptor blockers. So mainly if you see the diuretic action on the kidney, renal tubules, and these are the different diuretics where it acts in the proximal and the loop of and distal collecting tubules. And coming to the AC inhibitors and the ARBs, and these are the main now initiation of the drug therapy treatment. AC inhibitors or ARBs comes under the first line of treatment with high risk of associated with risk factors. So the beta blockers and calcium channel blockers. And cilindipine, if you say the advantage of the calcium channel blockers, mainly antioxidant action, it decreases urinary albumin excretion and renoprotective effect and glomerular protection, and it also helps in as an anti-anginal effect. And coming to the therapy, like initiation of the pharmacological therapy, combination therapy is the mainstay of treatment, where initiation is to be started like synergistic effect of the blood pressure lowering, and anti-hypertensive efficacy of combination therapy is greater than monotherapy, mainly especially in the subgroup of patients who are having risk factors, and decreased BP variability and reduction in adverse events and the lower rate of discontinuation, and allows dose titration. So according to the JNC 8 newer guidelines, mainly adult aged more than 18 years, implement of lifestyle interventions plays an important role, and then set blood pressure goals and initiate blood pressure lowering medications based on age, diabetic factors and diabetes and CKD. And then the general population's age of more than 60 years try to control blood pressure systolic of less than 150 and diastolic of less than 90, and age less than 60 or blood pressure goals systolic of less than 140 and diastolic of less than 90, and all ages diabetic patients maintain below 140/90, and all ages without diabetes below 140/90. So the set of the group of drugs where we have discussed before, the different subcategories according to the age factors and the involvement of the risk factors, you can choose accordingly and start. So target BP reduction, as we discussed before, 2014 guidelines, it's mainly less than 150/90 in more than 60 years, and less than 140/90 in general less than 60 years in diabetes and CKD patients. So compared to 2013 and 2018 European guidelines for the management of arterial hypertension, so the office BP is recommended in screening and diagnosis of hypertension, and the latest guidelines, the gold standard of ambulatory BP monitoring and home BP monitoring plays an important role for the diagnosis. And treatment, high normal BP 130 to 139 and 85 to 89 unless the necessary evidence is obtained. The newer guidelines says if the treatment may be considered when CV risk is high due to established CVD, especially coronary artery disease. And treatment threshold of grade 1 hypertension, initiation of antihypertensive therapies at a low moderate risk when BP is within the range, and repeated visits, and if it's elevated or even after the lifestyle measures. The newer guidelines says if any hypertensive mediated end organ damage or BP lowering treatment is recommended, and antihypertensives even after lifestyle intervention, lifestyle modification is done. So the starting the pharmacological treatment is advisable. So in older patients, previously at least when younger than 80 years, the systolic blood pressure they want to maintain should maintain 140 to 159, and the newer guidelines says more like lifestyle, after lifestyle and drug treatment, it is recommended in fit older patients more than 65 but not more than 80 years. Systolic blood pressure is to be under to maintain 140 to 159 provided the treatment is very well tolerated. So as a BP, systolic BP goal less than 140 millimeters mercury is recommended, and the BP treatment targets mainly the first objective should be less than 140/90, and in patients less than 65 years our target should be less than 128. So these are the different like optimal management where we see grade 1, grade 2, grade 3 and isolated systolic hypertension as we discussed before, and high normal BP, grade 1 hypertension and grade 2 hypertension and grade 3 hypertension. The aim of the BP management mainly to reduce the BP below 120 130/80 and to maintain in 120/80 segment, and people who are more than 65 years age to maintain under 140/90. So drug treatment strategies for mainly for coronary artery disease. There's a initiation of one pill therapy, and then increasing to the maximal dose, and then two pill therapy should be initiated. One pill therapy mainly a combination of drugs, mainly AC inhibitors or ARBs, along with the beta blockers, calcium channel blockers, or diuretics. The combination should be considered, and the systolic BP should be maintained under 150 if older than 80 years, and less than 65 years to maintain below 140. So then the triple combination of drugs you need to start first after initiating the dual drug therapy, and to maintain the BP under 130, 140, 90, and then increase the if the resistant hypertension happens, then increase the triple drug combination, or adding along with the spironolactone or other drugs, alpha blockers or beta blockers. And hypertension and chronic kidney disease initiation, like AC inhibitors or ARBs, along with the calcium channel blockers with diuretic, loop diuretics, and increase like initiation of the therapy with this combination, and then slowly increase if there is a resistant hypertension or the control of the hypertension is not achieved, then go to like step 2, and then resistant hypertension step 3. So blood pressure goals mainly with hypertension according to the clinical conditions. So as we discussed before, age more than 65 years, ESC guidelines 130 to 140, and diastolic of 70 to 79. AHA American guidelines less than 130, 80. Coronary artery disease, you need to maintain 130 and 80, and chronic kidney disease also like 130 to 140, and the diastolic of 80. So a few drug interactions and contraindications of few drugs like diuretics, contraindications of gout and beta blockers. You shouldn't be given in patients who are having asthma, any high grade sinoatrial nodal blocks or bradycardia, and calcium antagonists, also any bradycardia or sinoatrial blocks. And the AC inhibitors should be avoided in pregnancy and hyperkalemia, bilateral renal artery stenosis, and ARBs also should be avoided in this subset of patients. So complications, millions of patients remain at risk even after a serious medical complication related to the hypertension. Complications like stroke, cardiovascular disease, renal failure, vision loss, and premature mortality due to persistent elevation of blood pressure, underdiagnosed or improperly diagnosed hypertension, undertreated or uncontrolled hypertension. So these are the main factors where we see the complications if the hypertension and goals was not achieved. So prevention of complication, mainly patient education, dietary changes, increased physical activity, clinical vigilance, early and accurate diagnosis of high BP, achievement of target BP with individualized therapy. Thank you. Check. వస్తుందా? Hello, check, check, check. One second, shall I? Presentation on. Okay. Okay, good afternoon everybody. I'm Dr. Varsha Kiran. I'm a cardiologist at Apollo Health City, Hyderabad. Over the next few minutes, I'll be going through some case-based approach to resistant hypertension. I don't think any clinician goes past a day without encountering a patient with uncontrolled blood pressure. So I have no conflicts of interest to declare. So the scope of presentation will go through what the definition is and how prevalent it is, what are the risk factors that need to be looked at, how do we evaluate, and of course most importantly how to manage resistant hypertension. We'll be briefly talking about what's new with resistant hypertension, but we've got an entire talk lined up next talking about renal denervation. So let me start off with a couple of cases that we commonly encounter. It's a 38-year-old IT professional who's presented with recent onset fatigue and excessive sweating. Blood pressure was 220 by 110 at admission, and routine investigations including an ultrasound abdomen was normal. So because of this very high blood pressure, he was started off on a triple drug therapy consisting on olmesartan, amlodipine and hydrochlorothiazide. And after 2 weeks, he'd come back for follow-up and his blood pressure is still 160 by 80. So let me quickly run through the second case also. So it's a 56-year-old gentleman, is a diabetic and a hypertensive for 2 years. He's got blood pressure of 180 by 110 while on telmisartan and amlodipine combination. So now he's actually presented with progressive breathlessness for the past few days. So what is the best stepwise approach in this kind of situation? So let us just discuss a few things and then we'll come back to the case and see what we've learned over the presentation. So how do I define resistant hypertension? So any patient with a BP goal above target, that is 140 by 90 or 120 by 80 according to that subset, despite on 3 drugs, and important thing to remember is one of them has to be a diuretic. And another common fact which a lot of us miss out is all these drugs need to be given in the maximum specified dose or tolerated dose by the patients. So we need to understand there is this concept of apparent resistance versus true resistance. So whenever there is an improper technique of BP measurement at home or there is incompliance to medication, that more likely results in an apparent resistance rather than a true resistance. Also the white coat effect, that is whenever patients see the doctor, they get more anxious and the BP tends to be much higher, seems to be prevalent in almost 20 to 40% of the patients. So it's that's something that needs to be understood. So there is another entity called a cuff inflation hypertension among people who tend to check their blood pressure themselves. So when you actually inflate the cuff with the arm to measure blood pressure, that itself can erroneously raise the blood pressure. But nowadays I think most people are using digital machines back at home, so the possibility of cuff inflation hypertension is very unlikely. So some more definition. So it needs to be understood that resistant hypertension and uncontrolled hypertension is not the same. So anybody with basically BP goal achieved with more than 3 drugs, we tend to call them a controlled resistant hypertension. So people can have controlled resistant hypertension versus uncontrolled hypertension. And this is another term called refractory hypertension, when people are actually requiring 5 or more drugs including chlorthalidone and mineralocorticoid receptor antagonist. So kindly note the point that I specifically mentioned chlorthalidone, not any other diuretic, which we'll come back to later. And usually these patients tend to have a higher sympathetic tone, which results in a higher basal heart rate and higher systemic vascular resistance. So how common is resistant hypertension? Statistically around 10 to 20% across various studies done from Asian population as well as abroad. And like I already did mention, the white coat effect is seen in 20% of normal patients, but it may be present in up to 40% of patients with resistant hypertension. So what are the various risk factors to kind of predict somebody is likely to have a resistant hypertension or not? A higher baseline systolic blood pressure, presence of left ventricular hypertrophy on echo, obesity, older age group, presence of diabetes, long standing essentially, and various risk factors that have already been mentioned like excessive salt intake, excessive alcohol use, sedentary lifestyle, and also to note that significant medication interference with increasing the blood pressure, the most common of which
is the non-steroidal anti-inflammatory agents which people take for pain and various other reasons. Steroids, OCPs and sympathetic mimetics, a lot of cough medicines have sympathetic mimetics which tend to increase the blood pressure as well. So secondary hypertension in a normal public is seen only in around 5% of the time, but among people with resistant hypertension, some studies have noted in up to 50% of them. So what are the various common causes for secondary hypertension? Kidney disease is the most common, the chronic kidney disease for various reasons, or a renovascular hypertension. Obstructive sleep apnea, which is increasingly being addressed as a significant cause for uncontrolled hypertension over the past few years. Primary hyperaldosteronism accounts for almost 10 to 15% of uncontrolled hypertension, and 50% of them tend to have hypokalemia at presentation, which is a clinical clue for us. And other causes, various endocrine causes like thyroid dysfunction, Cushing's, pheochromocytoma, and etc. So how do we manage uncontrolled hypertension? First and foremost, we identify if there are any secondary causes, stop any medication that can increase the blood pressure, and of course reinstate the importance of lifestyle measures and address non-adherence, like increased pill burden may result in that. So by giving combination therapy, we can probably improve a better adherence to medication. Cost is a major factor in a country like ours, and also give careful importance to the adverse drug reactions also. Like a lot of patients with beta blocker don't tell us, but they stop medicine because of fatigue, impotence and various other reasons. So how do we evaluate for secondary causes? First and foremost, never ignore clinical clues. So anybody with a resistant hypertension, think of a secondary cause, and an acute rise in blood pressure over the preceding few days or weeks, and age of less than 30 years with very high blood pressure with no prior family history, obvious end organ damage, presence of metabolic alkalosis or hypokalemia, which kind of suggests a primary hyperaldosteronism, onset of blood pressure before puberty. All these will raise a suspicion for a possibility of secondary hypertension. And specific clinical clues for specific secondary causes, like renovascular hypertension, we often see the onset of hypertension is after the age of 55 years, and we also can see an increase in creatinine within a week of initiating ACE inhibitor or ARB medication. Ultrasound also gives a good clue in general evaluation, where there is a more than 1.5 centimeter size disparity between the kidneys. It's a good clinical clue to suggest a renovascular hypertension. Renal bruit, although we commonly do not see, its sensitivity is only around 40%. It's not a very specific test either to clinically detect a renal bruit. And most importantly, somebody presented with recurrent heart failure, flash pulmonary edema, it's a very strong predictor for likelihood of a renovascular hypertension. And this is some mnemonic to easily remember occurrence of pheochromocytoma. It's remembered as 5 P's, that is paroxysmal episodic hypertension, palpitations, pallor, perspiration and pounding headache. A lot of patients tend to describe it as feeling of impending doom as well. And other specific clinical clues like thyroid dysfunction, they can have features of hypo or hyperthyroidism, Cushing's disease where they have characteristic Cushingoid features. Coarctation of aorta, it's always necessary to measure peripheral pulse and document among patients with secondary hypertension, presence of a continuous murmur over the chest. These are all clinical clues which give an indication for any specific secondary causes. And as far as the lab evaluation is concerned, apart from the regular tests that we would otherwise do, thyroid function tests, urine metanephrines, specifically in the echo to look for a descending thoracic aorta gradient, which is not usually looked at, a renal artery Doppler and an aldosterone renin ratio. These are the common things that can be done if patients remain resistant. And how about stepwise pharmacological titration? So as I had previously mentioned before, our objective is to first start off with the first 3 groups of drugs, that is a ACE or an ARB, calcium channel blocker and a diuretic, and we need to maximize the dose of these 3 drugs before stepping on to the 4th drug. And also it is increasingly noted that a long acting thiazide diuretic like chlorthalidone or an indapamide is preferred over hydrochlorothiazide. So patients, if they are already on hydrochlorothiazide, we need to switch them to either chlorthalidone or indapamide, and among those with EGFR less than 30, where the effect of thiazide diuretics is less, we may start off with a loop diuretic like torsemide. And when we need to add 4th drug, based on the existing evidence and data, it is better to start off with a mineralocorticoid receptor antagonist like spirulolactone, As I did already mention, most patients with resistant hypertension tend to have primary or secondary hyperaldosteronism, which may result in high blood pressure. So based on these two trials, Pathway 2 was a randomized controlled trial which compared spironolactone, addition of spironolactone versus placebo, doxazosin or a beta blocker, carvedilol, and it found the maximum BP lowering effect was with spironolactone. ASCOT is more of an observational trial which compared spironolactone with placebo, and they found that as a fourth drug, spironolactone does better than the others. And if the BP does remain high beyond the addition of fourth drug, that is when you start the fifth drug and beyond, based on the compelling factors which we briefly went through in the previous presentation also. So if somebody has documented coronary artery disease or a tachycardia or fast basal heart rate of more than 70, then a vasodilating beta blocker would be a good fifth drug. Any of these like carvedilol, nebivolol or labetalol. Patient with CKD and an LV dysfunction, based on the trial data from African American population, nitrate and hydrolysin combination comes as a isoleucine tablet, may be better. And others like clonidine, minoxidil, prazosin, there are many other options which can be the add-on 6th and 7th drug provided the BP remains high. Just a point to note, the new drugs in development, an aminopeptidase A inhibitor which is still on phase 2 trial, that is firibastat, which is not yet clinically available. And small note on experimental therapies which are not really available to everybody. Of course, there is a talk coming up on renal sympathetic denervation. In brief, renal sympathetic denervation has mainly shown benefit in patients without resistant hypertension. So the Simplicity Hypertension 3 trial was the only trial which actually looked at patients with resistant hypertension, and unfortunately it did not show benefit. But the other trials like Sympathy and Dinarthin and also the new Spiral trials, they were all not including the patients with resistant hypertension on multiple drugs. There is another entity called baroreceptor activation therapy, where there a surgically implantable electrode is placed in the carotid bulb, which was evaluated in the Rios pivotal trial, which did not really show promising results, because of which it's been withdrawn. Of course, there is a new percutaneously implantable device which is under evaluation, and back in almost 7 to 8 years ago, people did look at surgical creation of AV fistula using an ROX AV coupler, which also did not show a lot of promise, and it's not really available. So I'll just briefly go through renovascular hypertension, which is commonly seen among most of our patients. Although in general population of hypertensives, it's only seen in 1 to 2% of them. Among those with refractory hypertension, 10 to 14% tend to have renovascular hypertension. So what are the important clues? On a Doppler, renal artery Doppler, a peak velocity of more than 200 correlates with a 60% stenosis. Of course, it's not a very specific entity. So a cutoff value of 300 per second is 300 centimeters per second tends to be more specific for a renal artery stenosis. CT or an MR angiogram showing more than 75% stenosis or a 50% stenosis with obvious post-stenotic dilatation is considered significant. So renal artery revascularization percutaneously performed, it can either be just a balloon angioplasty or stenting, depending on the patient profile. Like a fibromuscular dysplasia tends to get better with balloon angioplasty alone. Atherosclerotic patients may require stenting. And also it is important to know whether it is a unilateral renal artery stenosis versus a bilateral renal artery stenosis, including patients with single functional kidney, because among them there is unfortunately not much representation in the data we have, but logic would say that renal artery revascularization would improve outcome in them. So coming to the what is the data we have so far, the largest of the trials evaluating renal artery stenosis among patients with resistant hypertension is this CORAL trial, published way back in 2014 in NEJM. 974 patients with 2 or more drugs with renal artery stenosis, a 3.5 year follow-up showed no difference in primary outcome, that is occurrence of MACE, end-stage renal disease, stroke, heart failure or MI, and it only resulted in a very modest reduction in blood pressure with renal artery stenting of only 2.3 millimeter mercury. And also a point to note was around 2.2% of patients actually had a renal artery dissection during the procedure. So overall this trial doesn't really show a lot of promise in suggesting renal artery stenting or renal artery angioplasty routinely. And the other previous trial was this Astral trial, which is slightly older, which recruited 806 patients, but there was a 5-year follow-up which again showed no difference in MACE with an increased procedure related adverse reaction. So as of now, the best available existing evidence is this meta-analysis, which consists of 7 RCTs and 8 non-randomized observational studies. if you actually look at the graph on the left and the right, which shows effect on systolic blood pressure and the diastolic blood pressure, you can actually see the results are all over the place. Essentially, the randomized control trials are showing fairly uniformity in terms of no difference, but if you look at the observational trials, some are showing massive benefit, some are showing actually no benefit, so it's really not there. So what do we make out of this? I think we should actually take this with a lot of intuition, because if you look at the CORAL trial, they excluded patients with previous heart failure hospitalization within 30 days, which is exactly the profile where you suspect occurrence of renal artery stenosis. And also the mean antihypertensive drugs among the trial patients was only 2.1. So they are not all of them with resistant hypertension. They are not very high risk group to expect a significant benefit. And also 25% of study population had controlled blood pressure at enrollment. Another major criticism which is consistent with both CORAL and ASTRAL is most patients are actually unilateral renal stenosis. They are not patients with bilateral renal stenosis or stenosis in a unilateral single functional kidney. Another major criticism of an ASTRAL trial is more than half the patients did not have significant stenosis as per the current guidelines. So who would be an ideal candidate for renal angioplasty? So a person with bilateral renal artery stenosis or unilateral stenosis in a single functional kidney, short duration of uncontrolled blood pressure. So somebody who's been on antihypertensives for the last 10 to 12 years, who's come back to us with recent onset uncontrolled hypertension, in them we suspect a PTRA. And recurrent pulmonary edema, this is a very important factor. Patients who have drug intolerance or failure to control despite optimal medical treatment. So what are the outcomes we expect out of PTRA? Maximum antihypertensive effect actually is in the first 48 hours, and after that the effect tends to wane. But overall, if you look at the BP outcome, among 8 to 20% of them it totally normalizes, and 50 to 60% most often it actually helps in improving in BP outcome. And in about 1/4 of them, 20 to 30%, there is actually no benefit of renal artery stenting. What is the best predictor for durable BP control is a more than 20 millimeter mercury gradient across the stenosis after pepavirin infusion. And restenosis rate at 2 years is around 8 to 30%. So we'll come back to our case, we'll see what we have learnt. So going back to a 38-year-old IT professional who had a blood pressure of 220 by 110, whose triple drug therapy resulted in a BP lowering to 160 by 80. So what do we do next? Actually, if you look at it, the diastolic blood pressure is fairly okay. So this is the profile you should suspect a pseudo resistance. So step 1, we should probably account for occurrence of white coat hypertension. So maybe a home blood pressure or an ambulatory blood pressure would really help. And even there are data to say that even people who actually come to a clinic, it's better that BP checked by a technician or a nurse rather than the doctor, which can obviate the occurrence of white coat hypertension. Step 2, reiterate the importance of lifestyle measures. Then increase the medication dose to maximum. So this is where I was referring to. Maybe it's better we switch the olmesartan, amlo and hydrochlorothiazide to a chlorthalidone combination rather than hydrochlorothiazide. And of course, we should reevaluate for a possibility of secondary causes, change hydrochlorothiazide to chlorthalidone and indapamide, and then add the 4th drug, preferentially a mineralocorticoid receptor antagonist, either spironolactone or amiloride. And we'll come back to the second case. That was a 56-year-old gentleman who was diabetic hypertensive for 2 years on telma amlo combination. BP was 200 by 110 and he was admitted with a pulmonary edema. His echo showed normal LV systolic function and he had a shrunken kidney on the left side. So first step, because this patient is not on diuretic, I would add a diuretic, and the second step I would consider renal artery stenting in this patient. So if you can actually look at the angiogram, selective left renal angiogram, you can see a tight osteoproximal stenosis with a significant post-stenotic dilatation. After crossing, we just pre-dilated with a coronary balloon and deployed a 6 into 18 millimeter Herculean elite stent. You can look at the panel on the right side, you see the stent being expanded, and this is the final result after angioplasty with good angiographic outcome. So subsequently the patient was switched over to telmisartan, chlorthalidone and cilnidipine 10 mg twice a day, and he had stable renal parameters and he was discharged, and a few months later the blood pressure was 140 by 70. So I hope we met with the scope of the presentation. About renal artery denervation, that's something that I have not covered. We will be hearing more about it. If there are any questions, I'll be happy to take. Thank you.
Good afternoon, dear colleagues. I am Dr. Gokul Reddy, cardiologist in Apollo Hospitals. I will be discussing briefly about the renal denervation, a brief update only. As previously explained by previous speakers, the pathophysiology of hypertension involves the hyperactivity of sympathetic nervous system, which leads to increase in vasomotor tone. That is one of the reason why blood pressure can be high. To address that pathophysiology, this technique was developed, in which the sympathetic nervous system, which supplies the renal arteries to the kidneys, are blocked. So, initially I will spend few slides on what is the technique, how it is done, then I will explain you about the most recent data. This is a picture which shows that the nervous supply to the kidney is going around the renal artery to the kidneys. When we see the cross section, God has made it actually friendly for ablation. Like we have a lumen, we have media, you are adventitia, the renal arteries, the neural structures are just abutting the vascular pedicle. So that makes it easy for us to burn the lumen, from which the energy, whatever we use, the RF energy or the ultrasound energy, can go and block the nervous tissues. There are various methods to do the ablation to block the conduction. One of the most commonly used is RF energy, in which we engage the renal artery with a guide. We pass a RF ablation catheter through the artery. Then we select 4 points and ablate each point separately, so that they are each is done in different quarters. Like one you do in 25 degrees, 150, 175, 10. So that the neurovascular pedicle is actually blocked in toto. So you have another cross section which shows blue, orange, violet and yellow. These are the 4 different quadrants in which you are supposed to burn in 4 different planes. So that when you think that nerves are entirely covering the artery, each nerve is cut at one different point, so that the result is good and total there is a blockade of the nervous signals, sympathetic nervous system. This is the angio pictures, which again shows the guide, the RF catheter, and we usually there are few contraindications, like somebody has a renal stenosis, somebody has a diffuse atherosclerosis, somebody has a small renal artery, so a bifurcation too early should not be done. Otherwise, most of them are amenable for the procedure. Other technique is ultrasound guided, ultrasound energy, in which there is a balloon which is inflated, and there are 4 to 5 electrodes on the tip of the balloon. When we inflate and the balloon abuts the intima, we use ultrasound energy to generate heat, which actually does the same job what RF energy does. We have another called alcohol ablation, but not used mostly. Why was this developed actually? After the advent of or understanding about the pathophysiology, there were few studies preclinical in the dogs and the rats to understand whether really this technology works. There was surgical denervation done in canines and also in spontaneous hypertensive rats. Both of them proved that the blood pressure can be abolished. Other way around, when the reason of blood pressure was different, like in hypertension, in rats, the blood pressure induced by giving aldosterone receptor, or in canines by giving an NO synthesis inhibition. In these two subsets, the RDN didn't work. So probably the analysis was probably RDN might be selective in few experimental models also. So these are the various trials which have come in the last probably 12-14 years addressing this issue. So the first one, we actually raised a lot of hype about this therapy. It is Simplicity 1. It is a proof of concept, straightforward study which took 45 patients. They followed for 3 years. The results were spectacular, and this is the one actually which made all of us rethink about the treatment of blood pressure. In fact, one point of time, all of us thought that probably this is the way forward to go and the drugs can be minimized, because the results were spectacular. BP reduction of 32/15 at 24 months is really very, very good. One more thing was it showed that the LV mass reduced by 9%. There was a criticism for this because this was not a randomized study. There were no controls there, and a placebo effect was not ruled out. To address these criticisms, another trial was planned, that's called Simplicity 2 or Hypertension 2. This was randomized control. One group was on medication, one group had an RDN. All the patients were with blood pressure beyond 150 or 160 in normal or 150 diabetes, and all of them are on 3 or more medication for the blood pressure. And the follow-up was quite strict, 1, 3, 6 months, and at 6 months all of them had ambulatory blood pressure monitoring. Again, the results were carried forward, spectacular, like the Simplicity 1. The blood pressure decreased by 24 to 32 millimeters. That's a very, very great achievement. Then the hype was again increased. In fact, we also did a couple of cases with the radiofrequency catheter, which the EP guys use. Then the criticism was probably it's a placebo effect. Probably people who are undergoing intervention have placebo effect because of which the BP is decreasing and the rest BP is not. So that's the reason another trial was done. It was a very robust trial, Simplicity 3, in which the patients were identified, same criteria, BP of beyond 160, 3 medication full doses, no change for 2 weeks. They are followed for 2 weeks, saw that the blood pressure is similar. Again, they had a screening visit in which again the BP was checked. There was ambulatory blood pressure recording, which has to show the average is beyond 135. And in these patients, the urine and blood tests were done to document that the drug compliance was there. Then they were randomized. Eligible patients were done for observation, renal derivation, and one for sham procedure, in which the sham also taken to the cath lab, the artery was punctured, the renal angio was done and taken back. So that the patient feels that something was done for the kidney the denervation also. But only half of them had the denervation, rest of didn't have. So these were followed for 1, 3, and 6 months. When we see the results, these were not so encouraging. In fact, this showed that there is no difference between the two groups, people who had a sham and people who had denervation. Then there was a huge discussion saying that probably the sham or placebo effect is predominant as in the renal denervation. Then questions were raised whether this is really effective or not. But simultaneously, there was criticism also saying that this trial included a lot of centers which were first timers. So a lot of the, in fact, when they did a post hoc analysis, only 20% of the patients received the full RDN as per the guidelines. That means only 20% of them had full therapy, whereas rest didn't have. That was a criticism, and simultaneously, other company which does with the ultrasound system came with the results. This was again a multi-center, blinded, randomized, sham controlled study, like in the Simplicity 3. The system was not RF energy; it was ultrasound energy. They had 2 cohorts. One was a mild to moderate solo cohort, and the second was a resistant or a trio cohort. The study was conducted in the US and the Europe. This was a pretty robust study. Then the solo study, which showed in mild to moderate, showed that the blood pressure decreased by 8.5 millimeters in RDN and 2 in sham. That is significant compared to what it didn't show any difference in the Simplicity Hypertension 3. Then similar results were carried forward to the hypertension, the tryout study. This also showed that the blood pressure dropped by 9 millimeters mercury. So these two were very positive study. Then the company which manufactures which did the Simplicity got into action, and they devised 2 new studies. One was the spiral hypertension off med, and the other was on med, because there was a debate that probably this doesn't work well in patients who have uncontrolled hypertension. Probably it works well in patients with a mild to moderate or who are just to start hypertension. That's the reason they divided in 2 substrates, one with blood pressure off drugs, one with blood pressure on drugs. That's the reason. The off medication was only a 2 months follow-up. The on medication was a long term. Off med we can't continue for long term because of ethical reasons. So that's the reason only on med was continued for long term. So when they demonstrated the mean difference in blood pressure between two groups, the off med it was 5 by 4.4 and the on med was 7.4, 4.1. Both were statistically significant. So the blood pressure was less than the simplicity of 1 and 2, we showed 30 to 20 decrease. Here was 7 to 5, but statistically was very significant. Then recently, the long-term data of the spiral hypertension also published a couple of months back, which I'll spend 3-4 slides on this because it's very recent data. It's a randomized, single-blind, sham-controlled trial. Again, the entire US and Europe for the centers for it. The systolic blood pressure was 150 to 180, not very uncontrolled blood pressure. This blood pressure has to be 150 to 180. Diastolic has to be beyond 90. The patients were assigned to 1:1 for both RD and non-medical or sham basically. So the physician was unmasked for 12 months, and after 12 months they were allowed to crossover. Yeah, this is simple. At 26 months, the mean number of medication in RDN was 2.1 and the sham was 2.5. This itself was statistically important that RDN people required less of medication compared to sham individuals. At 36 months, the most important is in RDN group, there was 18.7 millimeters decrease in ambulatory blood pressure, which is very significant compared to 8.6 sham control. A 10 millimeter ambulatory is a very significant decrease in when you take the mean blood pressure. So this came as a very positive data. So at 6 months, the drop was 7.4. At 36 months, the mean was 5.5, 11 for systolic, and 11.8 for nighttime systolic. So to conclude, we can, based on these studies, which actually mix somewhere positive, somewhere negative, somewhere kind of a very super positive, somewhere kind of a absolute no result. What we can conclude is probably a therapy which would stay, probably needs more investigation before we can generalize for our patients. The 3 questions remains to be answered: is durable or not? The reason is, in the preclinical data of canines and rats, also the clinical follow-up, it was found that this general blood pressure comes to catch up in next 12 to 24 months. The reason is the preclinical data showed that almost like 70 to 80% of the nerves have renervation. Like you block all the nerves, within 1 to 2 years, 70% of them come back. So probably we don't know whether we need to repeat the procedures too often. And that's the reason durability is a question where probably as of now we have a 2 or 3 year data. Beyond that we don't know. And data shows that 70% of them reform in 1 to 2 years. And the method of ablation, here what is completion we don't know. We don't know a technology by which we can say that this is complete. The RF energy or the ultrasound balloon appears more promising because it gives there is not much of control in the operator. It has to be a balloon we dilate, the rest of the machine does. See, who are the population? Is it generalized or only for the mild to moderate, or for the people who don't have optimum blood pressure in spite of medication? It's not at test yet. So as of now, in our practice, we limit only to patients in whom, in spite of using 3 to 4 drugs, blood pressure not under control as an experimental modality only after full discussion. We haven't yet used for any patient as an first-line therapy. Even the guidelines also mention as an adjuvant therapy, not as a indication straightforward from the book. The other areas I would just touch on, heart failure, there have been few studies because we all know sympathetic nervous system stimulates the worsening of heart failure. So once there have been data, I would say not data, but few reports which say that in heart failure it works. There's one interesting thing in VT storm, what we call ventricular tachycardia storm. Also the RDN works in some people when all the other therapies are exhausted. There have been few reports work in sleep apnea, diabetes. That's too superfluous for us to discuss. Thank you. Is it